Hi, everybody. Thank you. Thank you very much, Professor Malcolm. I think it's very honor to me to present my topic in this big meetings. Let's start my topics. I press the button, share the screen, and okay, I will start. Hi, I'm DJ in Busan, Korea. Thanks, Chairman, for having me present in this big meeting, and Hoogland Spine for supporting biportal endoscopic spine surgery. Today, my topic is common mistakes of new recruit who are performing biportal endoscopic spine surgery, shortly BESS or UBE. BESS uses floating technique and keep the scope a certain distance apart from the target structures. We can move a scope freely and see the panoramic view just as open surgery. But through the floating interval, bleeding comes to our eyes first, so bleeding control and making surgical field clear are the key tricks in BESS. If you try to do something in bloody surgical field, you can injure the root or dura. We call it red screen. Under the red screen, you can make a root injury. So the first important knowledge you should keep in mind is vascular geometry in endoscopic view. Most vessels on the backside are coming from the segmental artery. It runs around the foramen and then makes several branches to the posterior side. So you can meet 3 main branches in posterior side and 3 branches in transforaminal approach, and there's another one called radical artery inside the foramen. At posterior approach, 9 o'clock left side, 7 at the bottom, and 5 o'clock right side are the main foci where bleeding comes out. If you know the main bleeding foci, you can guess where the bleeding comes out and control them easily, even in bloody, blurred surgical field. This is a map of vascular geometry around the foramen. You must be in trouble due to heavy bleeding when approaching around the foramen. In early learning curve period with no information of the vascular geometry. The first bleeding when you insert a scope on the transverse process TP is coming from the inferior arterial artery at 9 o'clock direction on the left side. That means if there is a big bleeding, but you cannot find the focus exactly, coagulate any region 9 o'clock left side first. The second, when you try to find a facet or SAP tip, this is one of the branches lying on the edge of the facet under the muscle. It is called the branch of superior arterial artery at 12 o'clock direction. It looks like a heavy rain. After capsulotomy, the interarticular branch runs under the capsule fiber, just beside the top of the SAP tip. So please prepare coagulation always when you scratch out the facet capsule. You can easily memorize the 4 main branches from the segmental artery. Just remember the magic spell 4 dragons on your fist. When you expect an exact direction where the bloody fire dragons attack, you can catch them with ease. Radical artery runs into the foramen inside and makes several branches. At first, you cannot notice its direction, but when you have special eyes on it, you can come to understand its shape and control extra bleeding easily. That is a map of extravascular geometry. You should keep in mind it becomes a map of the treasure island of BESS. Sometimes before we are not familiar with endoscopic anatomy and you have few reference anatomy in endoscopic view, you can easily lose your way and fall in panic in disorientation and spending about 1 or 2 hours in the interlaminar space outside, even without starting main procedure. We should know reference anatomy in endoscopic view. When you rotate the scope, the view also must be rotated, and then you can easily lose your direction. You should know what is the right reference view, and you should try to keep it same view in every trial. Standard base camp view in BESS, we can see 4 main structures as a reference anatomy: proximal spinous process and distal spinous process, and interspinous process ligament between them, and rotatory muscle bundle attaching to the dorsal surface of the lamina. Interspinous process ligament is an eminent structure which looks like a tornado. You can control the scope and make the tornado standing straight up rather than lying obliquely. Magic spell not to lose your way and direction is making tornado standing straight up. Incomplete decompression is so common in early learning curve period. One of the reasons is that we don't know how to access the pathology deeper and proximally locating. Interlaminar space is also very narrow in severe spinal stenosis, and there's not enough working space through which we can access the deeper main pathology. Literally, it is very difficult and tough to access the contralateral proximal area through narrow interlaminar space. So distal portion can be easily accessed and decompressed well, but proximal portions of the contralateral and ipsilateral sides are not easily accessed, and this can result in incomplete decompression. The 15 millimeter interlaminar space is needed for 8 millimeter diameter scope and 5 millimeter instrument. When you try to go inside of the spinal canal, especially into the contralateral side, to make a 50 millimeter interlaminar space, proximal and distal spinous process space should be resected about 5 millimeter each. If you have no idea of SP-based resection, you must be always in trouble and struggle in a narrow working space. And you never reach the contralateral side deeper, even contralateral side forming. SP-based resection is a key trick to give you enough working space for sufficient decompression under the sublaminar area. If you did not resect the SP base first and try to make a working space wider, then you finally resected the lamina too much. And you must do subtotal laminectomy in condition of lack of endoscopic anatomy information. Female 63, L45 severe spinal stenosis, posterior approach on the right side. Due to narrow working space, the surgeon did do total laminectomy on the right side and made iatrogenic instability with continuous mechanical back pain. Unless post of 2 months following up, fusion should be needed. The very best benefit of BESS is minimal laminectomy under maximal magnification and do sufficient decompression without fusion. This is another different case. Another subtotal laminectomy in one side was done and made a vacant facet joint, which lost totally one side articular process with the iatrogenic instability. We call it ugly BESS. To prevent this kind of wide laminectomy in a narrow working space, low portal position is recommended for severe spinal stenosis. In lower portal position, we can access a spinal canal with less resection of SP base and lamina. One of very unwanted complication to surgeons who are performing BESS first is dura tear. Because underwater and its narrow space, basically you cannot suture. It can be also prevented when you follow the basic rules. The unique anatomy underwater in BESS is the central dura folding at the midline. Due to saline water pressure, the size of the dura is compressed, so there becomes a dura folding at the midline, which is hidden under the epidural fat. In addition to central dura folding, the central fibrous band is located at the midline, which is connected with the dura membrane and undersurface of the ligament flavum. Don't try to remove it and clean up the midline fibers. When you pull out the central fibrous band forcefully, the central area of the dura can be injured. The first trick to prevent dura tear is to preserve deep layer of ligament flavum until finishing bony procedures. Boring without protection of deep layer of ligament flavum is the most common mistake of recruits in learning curve. There's a central dura folding under the epidural fat, so when you put an instrument deeper into the contralateral side under the fat layer, you can injure the central dura folding directly. Always be careful of the central dura folding in the midline. So, I will tell you where is a safe back door. You should remember that there are 3 layers in the epidural space: ligament flavum, fat, and dura. The safe way crossing the midline is that you should go between the ligament flavum and fat layers. Never try to go under the fat layers. Under the fat layer, there's a huge lion, so when you try to go under the epidural fat layer, the lion will catch you and swallow you in a big mouth. Always you definitely make dura tear several times, so you should know also how to treat it without conversion to open suture. One of the tricks you should know is how to insert the sticky tachosil on the dura surface. Cut the tachosil into the 2 pieces and folding it and envelope it with a gel foam. Folding it with the grasp with smooth gel foam and put it. This is called dura folding package. And this method is called patch compression method for incidental dura tear. Transforming approach is a very fancy and amazing technique of BESS, which is very best superior to the other open spinal surgery. But when you try to 1 or 2 first trials, you must make some unexpected complications. One of them is hyperperitoneum. Hyperperitoneum is a unique complication in transforming approach in using BESS. In case of L5 subformal decompression, after finishing surgery in a recovery room, patient belly looked swollen. CT showed hydrothorax and hyperperitoneum. Disorientation during formal approach and going deeper too much is the reason. In this case, one side of the body was eliminated with a huge Psoas hematoma. It looks very lucky. Corpectomy is just stopped before the big abdominal vessel. This is the standard view of transformal approach in left side. There are important reference anatomy structures: TP, transverse process, empty bundle, musculotendinous bundle, which can help you not to lose your orientation. SAP is not seen yet at first. SAP is hidden under the facet capsule and deep muscles. So you should remember two main guided structures, TP and empty bundle. Of course, there is a magic spell. Touch down the TP and look up the sky at 2 o'clock direction and run over the empty bundle. Then you can see the SAP tip. Never go under the empty bundle. When you go under the empty bundle, 100% you must make hyperperitoneum. Always keep in mind, touch down the TP, look up the sky at 2 o'clock direction, run over the empty bundle. You can easily remember the endoscopic anatomy around the foramen. Kung Fu Feast. Once you see that, you can easily remember the anatomic structures on the endoscopic view. Left thumb is the empty musculotendinous bundle. Right fist is the SAP tip. If you want to see SAP tip, which is the entrance door to the foramen, then you should run over the empty bundle. Never try to go under the empty bundle. When you have no complete 3D anatomic information over the foramen, you also could make incomplete decompression frequently. SAP has a very specific structures morphology, so you can easily understand endoscopic views and perform the ugly BESS. SAP has two plans, lateral plan and ventral plan. Lateral plan, which supports facet laterally, mostly it can compress or irritate the exciting root. Ventral plan, which is located at the foramen inside, which is the main pathology compressing an exciting root. So, ventral plan of SAP should be resected to decompress foraminal stenosis, but your first few cases of transforaminal approach could show remnant ventral plan. In a revision surgery, the ventral plan is resected and we can find a exciting root compressed under the remnant ventral plan of the SAP. Please remember that SAP has two plans. Lateral plan, which is located at the foramen lateral side, just supporting structure. After resecting the lateral plan, we can find the ventral plan located at the deeper side of the foramen. The ventral plan is a real pathology compressing an exciting root. Well, till now, I will let you know 7 magic spells which can save you from the very serious situations in early learning curve period. Without understanding these 7 magic spells, you can do ugly BESS in critical situation. I hope good luck and you and save many patients in your soil. BESS will always be with you whenever you call its name BESS, and you can be one of the strongest men controlling spine disorders safely and successfully. DJ is speaking now. Please remember DJ and 7 magic spells.
Thank you, everybody. Thank you.